Good morning. I am Dr. Ruzicka, nephrologist and hypertension specialist, and I would like to welcome you to what I consider the highlight of these days, and that's a debate which has a very hot title, Intensive Blood Pressure Lowering Improves Outcome. What is even more important, we have two very competitive speakers. We have Dr. Swapnil Hiremath, who is a nephrologist, hypertension specialist, associate professor at the University of Ottawa, and he is very active in debates. He did not have much luck in the past. He lost 3 out of 3. And so he is really looking forward to reverse that trend. It's going to be a very difficult job because his opponent is Dr. Scott Brimble, who is the Associate Professor of Medicine and Nephrology at the McMaster University. He's also provincial lead for nephrology in province of Ontario. And Dr. Swapnil Hiremath will be proposing that intensive blood pressure lowering improves outcomes. Therefore, that we should be aiming for lower blood pressure readings than we previously thought. And his opponent, Dr. Scott Brimble, will try to persuade you not so fast and not for everybody. But before I ask them to start, I would like to bring a couple of things, housekeeping things. So each of those speakers will have 20 minutes to present their case. Each of them will then have 5 minutes for rebuttals. And after that, I will present again the questions and you will vote. So there is going to be a question now at the beginning. I will show you 2 cases and you will read them carefully. And I will poll the audience. What do they think? Whether they think that the blood pressure should be left or whether it should be further decreased. So the first case we have is a 70-year-old man with history of hypertension, mild arterial disease, coronary artery disease, no history of stroke or diabetes. In office blood pressure check today, and he feels well. He is on 12.5 milligrams of hydrochloroside, and he's also on ramipril. His office blood pressure readings are 134/70. He has mildly decreased eGFR at 48, and his ACR is normal. And the question to you is, your next step is, leave the blood pressure as it is, less than 140/90, that's what we have there, or increase the blood pressure medication by adding other drugs and target blood pressure for less than 120 millimeters mercury systolic. I will ask you to vote on this. I think that all of you already vote. So most of you, 56%, would like to leave the blood pressure as it is, which means 134/70. Only 44% would intensify the medication. I will present the second case as well. And this is an 83-year-old man with history of hypertension, diabetes, stroke, atrial fibrillation. In office blood pressure is today at 134/70. This is his regular visit, and his wife is concerned that he is becoming more forgetful. He is also feeling fatigue and lightheaded at the times. And he is sick and tired of all these pills. That's what he tells you. He is on chlorthalidone 25 milligrams once daily. He's taking also ramipril 10 milligrams once daily, and amlodipine 10 milligrams once daily. And on the top of that, also bisoprolol 5 milligrams once daily. Besides that, he's also getting apixaban, atorvastatin, canagliflozin, insulin. So he has quite a collection of drugs to take every day. He's not sure if he took the medications today, but despite that, his blood pressure, as I said, is 134/70. And it's pretty much like that on the last couple of visits. His GFR is slightly decreased at 35. He has mildly elevated ACR at 25. And the question again is, would you leave the pressure as it is, meaning 134/70, or would you intensify the therapy and try to target the blood pressure, especially systolic blood pressure, to less than 120? I will let you to vote on this. Okay, we have a final result, and it is 67% of you would leave the blood pressure as it is. Only 33% would increase the medication and target blood pressure to less than 120. So I think that Dr. Hiremath has a lot of to explain here because he would go for less than 120. And I will now ask Dr. Hiremath to present his case.
Thanks. In fact, I think the second case is even worse, right? I think most of them wanted to leave as is. So yes, I have an uphill task in the next 20 minutes or so. So I'll try to make the case that lower is better. So in terms of disclosures, I am a member of the Hypertension Canada Guidelines work group. I do have grants in hypertension on adherence, salt restriction, potassium, and a few on non-hypertension topics. I don't have any industry funding or payments here. And the outline, there are three basic things that I'll talk about. What is the importance of blood pressure lowering? What do the guidelines say, and why do they say that? So what is the clinical trial data? So that's what we should be making our decisions based on. So unfortunately, hypertension prevalence, if you look at the global burden of disease data, the hypertension prevalence is increasing over time. And this is not just because of the aging population. So even after standardizing for age, we can see that the blood pressure rates are going up. And high blood pressure is associated with a lot of badness. So again, this is from the global burden of disease data. This is showing, the risk of cardiovascular circulatory diseases, CKD, ischemic and hemorrhagic strokes, and ischemic heart disease. So you can see here that the risk of these things going up, it doesn't go up just at 160. Yes, for sure, more than 160, more than 180, there is a lot of badness, but the vast majority of events happen in the 140 to 160 range, right? So a lot of people have this kind of blood pressure, and at a pressure of about 140 to between 140 and 160, you see the large proportion of cases are happening here. But even at 120, so where does the risk go up? It starts going up when the blood pressure is more than 120. So, don't think that it's only 140 or 160 that is to blame. The risk goes up, especially for stroke. It's almost a linear increase in the risk with higher blood pressure. But lowering blood pressure also is good, right? It's not that high blood pressure is associated with badness. If we lower blood pressure, it is good. So this is from the BP Trialist collaboration, and it shows that decreasing blood pressure, this is the standardized decrease of about 10 millimeter in systolic blood pressure. It reduces the relative risk reduction in MACE is about 20%. The relative risk reduction in stroke is about 30%. And the relative risk reduction in all-cause mortality is just over 10%. So these are huge things, right? Blood pressure is a silent killer. And if you lower blood pressure, you reduce your patient's risk of dying. Now, how low should you go? So one way to look at this is to look at the guidelines. So, and if we look at the guidelines, there is a veritable buffet of guidelines. You can pick and choose. But I'd like to show you, why you should use certain guidelines and not the other. This table shows a bunch of the guidelines, and I can understand why people do get confused, especially from certain universities in the GTA area. So you have to be careful when you look at these guidelines. So the American guidelines are like 130/80 for everyone. There are kidney disease improving global outcomes guidelines, which are like go below 120. And there are European guidelines, which are very strange. They say go to 130, don't go below 120. For diastolic, go below 80, but not below 70. So they are kind of, looking at precision medicine. They think you can keep a blood pressure in between a certain kind of a range. And they're mostly, at the higher end of the range. Now, the question is why Europeans or Americans, right? So the European guidelines are like, only lower the blood pressure if it is more than 140 and target less than 130, but not less than 120. If it is CKD, then go to less than 140. But if there is also diabetes, then go to less than 130, but not less than 120. And go to less than 130 on a Tuesday or maybe 140 on a Friday. No, I'm kidding, but they are very, very precise. Do this, but do not do that. The Americans, of course, are 130 over 80 for everyone. And you kind of wonder, why is this discrepancy? Partly it is because in the US, guidelines can become performance measures, and there can be, financial aspects to that. And they don't often use standardized blood pressure, AOBP, which is, in Canada, most of you used AOBP, either BP True or any other form of measuring blood pressure properly. And we won't go into the blood pressure measurement aspect today. Whereas the Europeans, they distrust the SPRINT trial, which will come up in a minute. And the fact that it was unattended. And I suspect it's mostly disguised nihilism, right? It's like, we don't believe this, we don't want to do it, let's do something else. Now, Dr. Brimble is from Hamilton, and I was looking up which Hamilton is this. He likes these European guidelines, it seems. And there is a Hamilton in what was previously a part of Europe. But I don't think he is from that Hamilton. I think he is from Canada. From Hamilton, which is located in Canada. So let's look at Canadian guidelines, right? We should follow Canadian guidelines, not European guidelines. So what do Canadian guidelines say? So the Hypertension Canada guidelines are pretty straightforward. If you start at 140 over 90, if there's diabetes, you go for 130 over 80. And if you're high cardiovascular risk, as described in SPRINT, you go for a systolic blood pressure of less than 120. So let's look at the SPRINT trial, because it often boils down to SPRINT. So SPRINT randomized patients to an intensive target, which was less than 120, versus the standard target, which was less than 140. And the inclusion criteria. So these are the kind of patients we are looking at, right? Your first patient and second patient. Are they over age of 50? Yes. Was their systolic blood pressure greater than 130? Yes. Do they have additional cardiovascular risk factors? For example, either clinical or subclinical cardiovascular disease? Do they have chronic kidney disease with a GFR of 20 to 60? Is their Framingham risk score more than 15%? Is their age more than 75 years? Yes. So if all these things are there, they are at high cardiovascular risk. They are at high risk of bad things happening. So if you have a patient who's got a high risk of bad things happening, how do we reduce their risk? They did have, of course, exclusions. So certain exclusions were there based on other trials that were going on. And what they found out was that the primary outcome, which was MACE, there was a 25% risk reduction. But more importantly, there's a risk reduction of death. So in these patients who are at high risk of dying, how do you reduce the risk of dying? By lowering the blood pressure to 120. So that's what you see in the SPRINT trial. What about some subgroups? So there was nothing, right? So all the subgroups, whether you have chronic kidney disease or not, whether your age is less than 75, more than 75, men or women, all throughout we saw that there was a benefit in all-cause mortality with SPRINT. And these are the two things that we can focus on: is that does your patient have prior chronic kidney disease, or are they elderly? And in both these subgroups, you can see that there was a benefit with lowering blood pressure to 120. But specifically looking at, I'm a nephrologist, so let's look at, and I think Dr. Brimble also is a nephrologist. So let's look at the patients we see. So in these patients, we saw that in the subgroup of just over 2,000 patients who had chronic kidney disease, we saw that there was a decrease in the risk of dying. The relative risk reduction is 22%. In cardiovascular death is even more, it's 43%. So there is a huge decrease in bad things from happening in patients with CKD if you lower their blood pressure. What about the elderly? So the elderly population was a pre-specified subgroup in SPRINT. So they looked at this specifically and they saw something very, very similar. In fact, this was even greater. So the risk of decrease of all-cause mortality reduction in people who are more than 75. So, age is not just an, oh, they're old, they're frail, let's not do this. That wasn't really true. In over 2,000 patients who were more than 75 years of age, going for a blood pressure of 120 reduced the risk of dying by 33%. These are big decreases in all-cause mortality. We don't see these kind of reductions in trials most days. Now, if you look at, where Dr. Brimble is from, he's from McMaster University. And if you go on their website, they say, come to McMaster. It's the birthplace of evidence-based healthcare. So I'm not really sure where he's going to go with his, higher targets. From whatever evidence we have seen, as far as the guidelines are concerned, as far as the clinical trials are concerned, they clearly show that going for a lower blood pressure is better. But maybe he's not convinced. Maybe I can show something more. So it's not just one trial, right? What we like to have is consistency. We don't want to have just one trial which shows that blood pressure is low, and all the other trials may show it is not, that lowering blood pressure doesn't decrease outcomes. So this was again the blood pressure lowering systematic review. This is a collaboration of trialists, and what they do is it's not just one clinical trial. They take all blood pressure lowering trials, and they get the individual patient data and they put it together into a meta-analysis. So this is sort of, if you look at the evidence pyramid that you may see at McMaster, it's, you have clinical trials and they have meta-analysis of clinical trials right on top. So I'm talking about the top of the evidence-based pyramid from Dr. Brimble's institution. And this is what you see. So firstly, if you look at the reduction in systolic blood pressure, and looking at it as a scatter plot, you can see that the lower the blood pressure, the greater the reduction in systolic blood pressure, the greater is the benefit that you're going to get overall in all these clinical trials put together. This graph again showing that when it comes to outcomes, your a 10 millimeter reduction in systolic BP reduces major adverse cardiovascular events, it reduces stroke, and it reduces risk of dying. But you can think about, hey, what is the starting blood pressure? Maybe you're going from 160 to 150. Not really. So this is showing, at this end, you can see the starting blood pressure. Was it less than 130? Was it 130 to 140? Was it 140 to 150, and so on? And you can see here that irrespective for all these outcomes, whether you started at a blood pressure of less than 130 or more than 160, in major cardiovascular events, in coronary heart disease, for stroke, for heart failure, and for all-cause mortality, there is a benefit, ranging from 20%, almost 30% to about 13%. For kidney failure, the data is not that strong for intensive BP lowering. But for all the other outcomes, not only is there a benefit, but the benefit is seen regardless of what your starting blood pressure is. Whether you start off at 160 or you start off at 130, you get a very consistent benefit in the reduction in MACE, in stroke, in heart failure, in all-cause mortality. So I'm not just talking of the SPRINT trial, I'm talking about the overall comprehensive, evidence base. Looking at the overall complete evidence base, there is a consistent reduction in all sorts of bad things happening from lowering blood pressure. Unfortunately, though, what we see here, and this is the enhanced data from the US, and there is similar data from Canada. What we see is that there is a movement saying, hey, less is more, let's do less. And what is happening with that is that blood pressure control is worsening. It's worsening in the US, it's worsening in Canada, and it's worsening in many other jurisdictions. And they used a threshold of 140 over 90. This is not the guidelines that made them choose this. So you can see here that blood pressure control is worsening, probably because of attempts by people like my opponent here. And why should you not lower blood pressure? Is it ageism? It's like, oh, the patient is too old, let them be. I would say it's possibly it's therapeutic nihilism, right? Why, it's too late, why bother, let it be. And a lot of it is the distrust about SPRINT. It's like, oh, we don't believe in the SPRINT trial, right? Don't bring up that issue. It upsets me. And possibly those are the factors that are causing Dr. Brimble to let the blood pressure be high. So I'll let Dr. Brimble take over now. I'll just mention a couple of things. Is that when we were looking for opponents for us, it was hard to find anyone to disagree, right? This is like, it's so clear. The evidence that I've shown is so clear. It's crystal clear. Lowering blood pressure is improving outcomes. It decreases your risk of dying. Who is going to disagree with that? Who is going to argue against that position? There is Dr. Brimble. So if you go on Twitter, there is a hashtag called Scott Disagrees. It's really there. And whatever position you take, right? If you say the sun rises in the east, Scott will jump up and say, are you really sure? Maybe tomorrow it won't. So for any kind of position, if we want to find something to disagree with, Dr. Brimble is there. So with that, I'll let him try to convince you of this unscientific, non-evidence-based position that he's taking.
Thank you, Dr. Hiremath. It was a nice presentation. I hope that everybody listened very carefully. And I would now ask Dr. Scott Brimble to take the opposite view. Dr. Brimble. Scott, you are muted.
Of course I am. Sorry about that. Okay, so again, thank you very much for the opportunity to speak to you all today, and thank you for that beating I took there, Dr. Hiremath. So I'm going to argue the con side, and I'm cheating a bit and changing the title a bit of my talk, and that's that intensive blood pressure lowering is not for everyone. Disclosures, so I think as already mentioned, I'm a provincial medical lead at Ontario Renal Network, which is part of Ontario Health. I do not have any industry associations. And, you know, Dr. Hiremath presented himself as the underdog here, but in fact, it is me. And I just want to kind of quickly outline why that is. You know, I'm not a researcher like Dr. Hiremath is. You know, he's had 73 publications in hypertension, blood pressure. I've only had 5, and nobody's read any of the ones I've done. So that's important. I'm not on these fancy guideline committees that Dr. Hiremath is on. You know, he's mentioned Hypertension Canada, I think about 12 times already in his talk. He's quite proud of that one. You know, and I'm not the Twitter legend that Dr. Hiremath is. You can see here he has about 15,000 followers. He's tweeted about 85,000 times. So it takes about 6 tweets to get a follower. I don't know if that's a good ratio or not. I don't have my own podcast. I don't know if you know, he has his own podcast. You can see him there in the middle looking at it like he's about 25 years old there. So he's got a nephrology podcast. He even has his own book on hypertension now. Who knew this? Hypertension Secrets. So again, I'm the underdog here, not Dr. Hiremath. So what do I bring to the table? I just take care of patients. Clearly, Dr. Hiremath's way too busy with all these other things he does to actually see patients. So before we dive in to my talk, I just want to clarify that when we talk about intensive blood pressure lowering, we're talking about a systolic blood pressure of less than 120, as from SPRINT. So I'm going to argue a few points. One, that maybe these results from SPRINT are not generalizable to all patients, and I'll focus particularly on those with chronic kidney disease and those who are frail or elderly, although I could talk about diabetes and other categories as well. And I do want to touch briefly on what was called standard care in SPRINT, and that might have some relevance for the cases that we presented. And then I do want to just kind of assume right up front that we're all doing the blood pressure properly, with the automated cuffs and in a controlled environment. So I won't touch more on that. And thank you again to SWAP for outlining what happened in SPRINT. So over 9,000 patients, they had a blood pressure greater than 130, good MACE outcome. And the 2 groups that they compared were less than 120 versus less than 140 for systolic blood pressure. They got excellent separation of the blood pressure, as you can see there. It is interesting that you do see that pretty significant drop in the blood pressure in the standard group, sort of right after enrollment. And you often see that due to perhaps increased patient adherence and just generally greater scrutiny of the patients. And as he outlined, 25% risk reduction in MACE outcomes, as well as all-cause mortality. And this is exciting and really groundbreaking clinical trial. So the question I have again is, are these results generalizable? Dr. Hiremath talked about the exclusion criteria. So we'll touch on that. So the inclusion criteria really, I think, quite reasonable. Patients at least 50 years of age, blood pressure anywhere between 130 and 180, depending on the number of antihypertensives they were on. So you couldn't be on more than 4 blood pressure pills. And you had to have high cardiovascular risk, so that could be clinical or subclinical cardiovascular disease, although excluding stroke. CKD, so an eGFR between 20 or 59 could get you in, or have a Framingham 10-year risk score of at least 15% would get you in, and finally an age of at least 75 years. So that all seems quite reasonable. Dr. Hiremath spent about 3 milliseconds talking about the exclusion criteria. Maybe we could drill into those just a little bit more. So here's a maybe 1 or 2 days worth of patients in your clinic here. Uh-oh, there goes the ones with diabetes. So we have to take those out of consideration for sprint. Those with active cancer being treated, those who've had a stroke before, those who have symptomatic heart failure, those who have dementia or live in a nursing home, those with CKD that have proteinuria or an eGFR less than 20 or polycystic kidney disease, gone. If patients had a limited life expectancy less than 3 years, or if they had orthostatic hypotension, at least 10 others. So, I do think we need to keep that in mind when we're trying to generalize the results of sprint to our patients. When we look at what patients actually sort of were left and were enrolled in sprint, average age was 68, 36% were female, baseline blood pressure 140 over 78, average eGFR is 72, despite an aggressive approach to getting patients with chronic kidney disease in sprint. They did not meet their enrollment target for patients with CKD. And the average number of blood pressure pills was 1.8. And certainly we have patients, with 1 or 2 blood pressure meds, but we have many patients who require more than that number. So I have a few questions here to address. So one, how did they manage those patients in standard care? And this is really relevant, I think. So if you were randomized to standard care and your systolic blood pressure was less than 130 at that visit, or you had 2 visits where it was less than 135, no, you didn't simply leave them on the blood pressure pills they were on. You actually reduced them at that time. And we'll come back to that with that first case. And the results of that meant that over 1/3 of the patients in the standard care group were on 0 or 1 blood pressure pill at the end of the trial. So again, when we're thinking about many of the patients where we're considering more aggressive targeting of their blood pressure, how many of them are on none or 1 blood pressure pill? And I just quickly remind you of that first case, where that blood pressure is 134 over 70. If that was the second time that reading was had, what would you actually do is you would have had to stop, for example, the hydrochlorothiazide if they were randomized to the standard group. You couldn't simply leave that patient on the same medications. And perhaps that change was associated with harm. Okay, so Dr. Hiremath talked about patients with chronic kidney disease. Let's talk about that a little bit more. So this was from the principal paper. They showed that there was no interaction between group assignment and the presence of chronic kidney disease. Therefore, the results are valid for all people with chronic kidney disease, perhaps. Well, let's think about that a little bit more. Again, I've showed you some, but not all, the exclusion criteria. So that's quite a few criteria might apply to your patients. When I looked at my practice, 100 patients, consecutive patients, only 15 of them actually would have been eligible for sprint for reasons of things like diabetes and proteinuria. Now, perhaps that may not be the same as in your practice, but I suspect a high proportion of your patients would not be eligible. And then when we drill down a little bit more about what actually happened in chronic kidney disease, we actually find out that when you compare intensive versus standard treatment in patients with chronic kidney disease, the difference was only 19 events. And when that's compared to the fact that there were 245 participants who were actually lost to follow-up and another 275 who withdrew consent. So only a 19 event difference between the two groups. And when we look further, somewhat concerning, I think, what we actually find out is that 19 patient or 19 outcome difference was exclusively in patients who had an eGFR between 45 and 60. Those who had an eGFR less than 45, there were 54 events in the intensive group and 54 events in the standard group. However, when we again look at those with an eGFR less than 45, the risk of developing acute kidney injury in the intensive blood pressure lowering group was 2-fold higher. So I think this is compelling data to suggest that we need to be much more cautious in our more advanced CKD patients. And by advanced, I'm only referring to those with an eGFR less than 45. As Dr. Hiremath mentioned, we can't just look at sprint. There's other data out there. He showed you one systematic review. Here's another one looking at all-cause mortality. Did they see a difference? You can see that the odds ratio there, or the overall odds ratio 0.86, does not cross 1. So that's suggestive of compelling evidence that we should be aggressively lowering blood pressure. However, when you kind of synthesize those articles and look at sort of the average blood pressure achieved between standard and intensive, it was only 132 versus 140. I think many of us would think, targeting a blood pressure to 130 seems quite doable, quite reasonable. 120 seems a little bit more challenging and perhaps more risk of harm. Speaking of risk of harm, let's talk about the frail and the elderly patients with our third question here. So again, Dr. Hiremath nicely pointed out that in sprint, there was no interaction between age defined as less than 75 or 75 or older. So therefore, again, perhaps the case is closed and we shouldn't worry about intensive blood pressure lowering in the elderly. Well, hang on a minute. Again, are these patients the kind of patients that we see in our clinics? So here's a cohort of over 15,000 patients, at least 80 years of age. And this is based on EMR data from primary care. This is patients, type of patients that you're seeing in your clinic. When they looked at this cohort, only 1/3 of patients, again, would have been eligible for sprint, even though they would have all met eligibility criteria based on age. And not surprisingly, it's for reasons like diabetes, stroke, dementia, orthostatic hypotension. And when they looked at predictors of not being eligible for sprint, it was things like frailty, cardiovascular polypharmacy, which is only 3 cardiovascular meds, aspirin, a statin, and 1 blood pressure pill. You qualify as polypharmacy. And multimorbidity, again, many of our elderly patients have many medical issues going on. Much was made of sprint and frailty. They did have a measure of frailty and said, hey, look, our patients are just as frail as other randomized trials. But when you actually look at other cohort data, so for example, the TILDA study, which was a longitudinal aging study from Ireland, what they found is that patients in their cohort were 5 times more likely to have an injurious fall or a syncopal episode. So again, it raises the question of whether patients in sprint who were elderly were really as frail as many of the patients that we're taking care of. Dr. Hiremath didn't mention this study, but this is a recent randomized controlled trial where they did try again to get older patients to a more aggressive blood pressure target, so 110 to 130 versus 130 to 150. The primary outcome very similar to sprint, and they were not as successful as getting the same sort of degree of separation. So the intensive group, they only got down to 127.5, so say less than 130. And again, the hazard ratio was impressive, very similar to sprint, 0.74. But when you kind of really look at it, take away the sort of blown up figure and have a look at the difference in outcomes between the two groups. If you're talking to your patient using shared decision making and showing them this graph and saying, are you interested in going on another blood pressure pill? You might have a difficult argument to make looking at a graph like this. There have been other studies, systematic reviews looking at those who are older. This is a synthesis of randomized trials where the target for the intervention group was less than 140, it could be less than 130, it could be less than 120. This is all trials where it was at least less than 140. And you can see, for example, the CORD, the study in diabetes, a little bit of a signal to increased mortality. Sprint, the one in the middle there, seems to be a bit of an outlier. And overall, there was no evidence of benefit for more aggressive targeting in elderly patients. Perhaps the most important question of all, though, is this expert, Dr. Hiremath, who's on guidelines, writes textbooks, podcasts, does he really honestly think that we should lower the blood pressure less than 120 And even if he did, can he actually get the job done? So I mentioned he's tweeted about 85,000 times. I recently found this one here from Dr. Hiremath. This was 4.5 years after Sprint was published. He acknowledges he's a strong Sprint supporter. He again mentions he's part of Hypertension Canada. He's very proud of that. And then the question was, he's one of the first people to say we should get the blood pressure less than 120, and yet 4.5 years later, he said very few of my patients are actually at less than 120. And he acknowledges before Sprint, he was very busy de-prescribing, de-escalating therapy. And you can see the impact of this tweet. In fact, he had a total of 1 like. So sorry about that, Dr. Hiremath. We did write a review with our moderator here as well, Precision Medicine for Hypertension Management and CKD. And here's a direct quote. One has to be careful while extrapolating the results of Sprint and applying those targets to all non-diabetic CKD patients. So he's already said we shouldn't do this in diabetes with the first line. Sprint was designed to exclude patients who would be more likely to have serious adverse events, such as those with postural hypotension, dementia, or residing in a nursing home. So, he does seem to be agreeing with me here. And then curiously, in one of the tables, he actually acknowledged that these trials did not appear to show any benefit, which was rather curious. So I do think Dr. Hiremath does have a bit of an uphill battle. So I'm going to just close here. So again, I do want to acknowledge Sprint was a remarkably important study. It's practice changing. I just think there's a lot of nuance to consider here, particularly in the primary care setting where patients are going to be much more heterogeneous than they are in a clinical trial. We should not be treating all of our patients to a target systolic less than 120, particularly those with CKD and those who are frail. And even if we wanted to, Dr. Hiremath says we can't get the job done anyway. And rather than just kind of taking a blanket approach, I think you do need to consider the context of all the available evidence, and most importantly, that patient in front of you. And Dr. Hiremath again mentioned in Hypertension Canada, and for CKD, they said individualized BP targets in those with CKD and consider intensive targets in appropriate patients. And I think that's actually great advice. So when we think again, when you reflect on those 2 cases again, that first patient here, would you lower the blood pressure? I'd argue, you could intensify therapy, absolutely, but just keep in mind that in Sprint, they would have actually de-escalated treatment for this patient if they were randomized to standard care. So that's something to reflect on. And for that second patient with all this stuff going on and polypharmacy, do we intensify therapy? I would say hell no. So I'll finish there, and again, thank you for your time.
Thank you, Scott. It was a very well done presentation. I will now ask Dr. Hiremath for rebuttal. You have 5 minutes. Go.
Thank you for that. I think Scott's just jealous. He has got like 200 followers on Twitter, and that is just showing he's been trawling to find stuff to complain about. Now he criticized Sprint a lot, Dr. Brimble did, but if you look at Sprint, it was an efficacy trial. It was not a pragmatic effectiveness trial, right? So you need to have separation. If you're doing a trial of statin versus no statins, you try to make sure that the patients who are not randomized to statin are not getting a statin. And despite that, of course, there is some contamination. So that was the reason. If your intensive arm is at 121 and even the standard arm is at 125, then what is the point? Then you will really have a non-informative trial rather than an informative trial. And this is why I say it was better. If you look at the blood pressure in other trials like HOT, the actual blood pressure was it was a diastolic blood pressure target, not a systolic blood pressure trial. And the blood pressures were like 81 and 83. So no wonder they did not show a difference. It's because Sprint was a better trial. It had a nice separation of blood pressure to show a benefit in the first place. And there was a lot of talk of polypharmacy. If you actually see that, if you look at the median difference in the number of blood pressure medications that were taken, it was just over 1 with the intensive arm. So we are not talking about, giving them 10 different medications. And as you saw earlier in today's sessions, what we are trying to do is to use medications in a smarter way. So not adding 4, 5, 6 medications, but instead of, ramipril, which is the favorite at McMaster, give them a more potent ACE inhibitor or an ARB like perindopril or olmesartan. Instead of the hydrochlorothiazide, give them chlorthalidone or indapamide. Even like these are generic medications. There is no industry conflict there. They're very cheap. So it's possible to keep the number of medications low. And these were the, chlorthalidone was the thiazide of choice, for example, in SPRINT. So it is possible to get your blood pressure down very well without, just adding on pills after pills after pills. And yes, I agree about the exceptions. These are some important exceptions. It's not just, institutionalized patients, but if they were on a wheelchair, if they're at high risk of falls, and I would agree, the second patient, he's lightheaded. I would not escalate their therapy without checking their standing blood pressure. Or if you had a feeling that they are at high risk of falls, yeah, it's not worth it. You are going to, cause more harm potentially than give them a benefit. But that's something we should perhaps be doing more often. We do measure standing blood pressure in my hypertension clinic, but if I go to my general nephrology clinic, I forget what I'm doing there, and we don't measure standing blood pressure that often. I would argue that measuring standing blood pressure should be an important component, especially if you are going for intensive BP lowering. And yes, this is really important. This was a sub-study of SPRINT, and they looked at what factors were associated with failure to achieve intensive BP target. So not everyone did reach 120. So older age and CKD, these are the patients where it is not easy to reach the target of 120. Those with even with higher starting systolic blood pressure, they also had more serious adverse events, which are mostly falls. So these are not easy patients. It's not that you just say, oh, just take one more pill, I wanted 120. I'm not talking about one size fits all solution in this situation. And blood pressure does drop in the later end of life. This was an observational study in JAMA, which looked at the blood pressure for the last few years before someone died. And we do see that as people are getting more frail, as they're aging, that you may see the blood pressure actually go down. And it's fine. I'm not just someone who will say prescribe. It's okay sometimes to step back and say you should de-prescribe. But at the same time, let's not forget, let's keep our eyes on the ball. High blood pressure is bad for stroke mortality. This is over 1 million patient data showing that it's a linear risk. For some people, the quality of life may be important. Stroke may be important, right, for them. And I think stroke is something that some people fear worse than death. So it's important to try to lower blood pressure. If it is possible to do it safely, please do so. Don't just, say hell no and walk away. Many times it is possible to lower the blood pressure. In my opinion, this is strictly my personal opinion. If you've got a young patient with no comorbid conditions, yeah, 140/90 is fine. Focus on their lifestyle, minimize the pills, because it's a long haul. They have a long way to go. But if they are more than 50 and they have comorbid conditions, you aim for 120, right? And the keyword here is that you aim for 120. You may or may not achieve 120. Even in SPRINT, they did not achieve 120. And you maximize the pill potency. Use pharmacotherapy in a smart way. On the other hand, if you have got someone who is older, they are at high risk of falls, you have got them on 4 or 5 medications, they're at good doses, including a thiazide like pill, spironolactone. Consider referring these patients, of course, to a specialist, but it's okay to individualize, right? You don't want to add the minoxidil and the clonidine and the beta blocker and the alpha blocker in these kind of patients. So with that, I'll stop and I'll let Scott have his rebuttal.
Dr. Brimble, your turn. There's a lot of blood on the street already.
Well, I think, Dr. Hiremath and I actually probably are fairly aligned here. I had an opportunity to respond to a few things during the talk, so I won't spend as much time in my rebuttal. I would just sort of say, again, he said, it's just one pill difference between the two groups. I think many of us find that a number of our patients, one pill does not make that same degree of difference. And I just wanted to quickly share with you, I had the good fortune to work with family doctor, Dr. Alan Grill, to kind of co-develop KidneyWise Toolkit, which hopefully you've heard of. And, we brought together a number of people to kind of, really drill down on the blood pressure targeting, including our moderator. And the interesting thing in the process, we had a number of family doctors who were with us there, and they really, pushed hard for, the fact that we need to consider, yes, less than 120 over, 80 or 90, or just targeting the systolic less than 120. That's a worthy goal because, as Dr. Hiremath said, hypertension, it's associated with bad outcomes. And if we can safely lower blood pressure without impacting on quality of life, I think, that's a worthy goal. But they, as the family doctors in the room, we said, but hang on a minute, we're seeing patients who are very frail, nursing homes, they've had previous strokes, limited life expectancy. Polypharmacy came up again and again and again. It was very interesting that it was, this sort of, this little box here that we came up with was really driven by the family doctors in the room, not so much by the nephrologist in the room. And that's stuck with me all along. And again, I think it's really important to think about the patients in front of you, and in the era of shared decision making, really, bring the patient or the caregiver into the conversation and deciding, the risks and benefits of more intensive lowering, considering life expectancy. And I enjoyed some of the earlier comments as Dr. Hiremath was talking about doing his presentation, kind of reiterating some of those points. So I will stop there.
Okay, thank you both for your presentations and rebuttals. I would like to remind everybody that we had 2 cases, and I will ask you to vote on what would you do in those 2 clinical scenarios. The first situation was a 70-year-old man with history of hypertension and CAD, no history of stroke or diabetes, and with blood pressure 130 over 70 on just 2 blood pressure lowering drugs, mildly decreased kidney function, and no clinically significant proteinuria. And the question was whether you would leave it or whether you would aim for intensification of the blood pressure lowering therapy. So I will ask you to vote on that. And 75% of you would, 77% of you would intensify the blood pressure lowering regimen. Only 23% of you would leave it as it is. So on this particular case, I think that you all agree that the blood pressure should be decreased. And I think that that was actually a mutual agreement between the 2 opponents here. They were not really having opposing view on this. Dr. Brimble would push or at least try to decrease blood pressure further in this particular scenario. And so that was opinion of Dr. Hiremath as well. I think that much more interesting is the second case, if I can have it there again. And here we have an 83-year-old man with history of hypertension, diabetes, atrial fibrillation, with sort of a moderate chronic kidney disease with eGFR of 35. There is some microalbuminuria, and the patient is already on 4 blood pressure lowering drugs. He is fed up with that. In addition to those 4 blood pressure lowering drugs, he is taking additional 4 or 5 other drugs for other comorbidities, and he feels fatigued and lightheaded at the times. We don't know what his standing blood pressure is, but his regular blood pressure in the office is 134 over 70. And here we have a really scenario where Dr. Hiremath would push the blood pressure below 1, or at least try to achieve the blood pressure lower than what it is right now. And Dr. Brimble would be more careful. And actually his response was hell no, to remind you that. So I would like to ask you to vote on this particular scenario, because that was probably the most important one. So we can start. And I am afraid that
It's 99, 97 to 3. Wow.
97% would leave it as it is, and only 3% of you would push the luck and going further. So on this second scenario, which was clinically relevant, I think Dr. Brimble has to be declared a clear winner. Congratulations. But the things are not as black and white as one thinks. I saw a lot of comments and questions going on here. And I think that both speakers actually pointed out very important things, and that is guidelines are just guidelines. They provide you with some evidence and what expert thinks is to be considered. That doesn't mean that you have to do it. You have to approach every single patient as an individual and find out whether for that particular patient that evidence really matters, and whether that would really make a difference if it's applied for that patient. So I think that both speakers actually agreed that the care should be individualized. And one of the things which was frequently mentioned in the comments here was whether these patients should be consented. And I think that our guidelines in Canada, doesn't mean that you have to follow them, actually supports that if you are going for that lower blood pressure target, that you should explain to the patient what you are doing, what are the potential negative outcomes, and document that, and only go ahead with that decision if you do have agreement, if it comes to a mutual agreement between you and patient. And there was one additional question here, and that was about the elderly going to Florida, I guess, for the winter, and that the change in medication would have an impact on their insurance, etc. Again, I go back to what I said. Guidelines are just guidelines. Whether you will go ahead with intensified blood pressure lowering regimen, and when you do it, and how you do it, over what period of time, that's entirely your individual decision. Whether Dr. Brimble or Dr. Hiremath would like to make additional comment with regards to conclusion. Dr. Brimble, who is the winner of the second case.
Yeah, no, I think it's been summarized very well, and yeah, no, I think very thoughtful comments as well, and from those who are listening today. So again, thanks to everyone.
Thank you very much for participating, Scott. And Dr. Hiremath, your turn.
Yeah, and I mean, you said it well. We agree. You know, the point of these debates is not necessarily for a winner or a loser, but just to highlight the tension sometimes. These are not easy decisions. It's not like, you're going to give antibiotics for pneumonia, or you're going to give a vaccine for COVID. Those are simple ones. These are the areas where there is some gray, and where, two people can look at the same situation and come with slightly different answers, especially. So that's what we were trying to highlight in the debate. And I think it was a great discussion. Thanks for doing this, Scott.
I would add one more thing, that what the views they represent, they do not necessarily represent what they do. And you saw that Dr. Hiremath published a lot of things with me where his views were opposite to what he had to defend today. So that's really what it is. But at the end, I would really like to thank both of the speakers for absolutely outstanding performance and excellent review of the evidence. And I am happy that we came to mutual agreement at the end what should be really done for the patients. Thank you very much all for participating. And one question was whether the slides of these two presenters will be available. I said yes, but I would like to confirm that with Dr. Brimble and Dr. Hiremath.
Yeah, they will be available. I think we were trying to hold them back until the debate actually was over. So they will be available, and the recording itself will be available for a year.
Okay, thank everybody, and enjoy the rest of your day.
Thank you.